Welcome to KDIGO Conversations in Nephrology. This episode is titled, Approaches to RASi Optimization. For disclosure information, please go to kdigo.org/podcasts. Here's your host, Dr. Roberto Pecoits-Filho.
Hello and welcome to the KDIGO Conversations in Nephrology. I am Dr. Roberto Pecoits-Filho, Senior Research Scientist at the Arbor Research Collaborative for Health, and Professor of Medicine at the Pontifical Catholic University of Paraná. On the program with me today to discuss approaches to the optimization of renin-angiotensin-aldosterone system inhibition is Dr. Patrick Rossignol. Dr. Rossignol is a nephrologist and a vascular medicine specialist, so certainly the perfect guest for our topic today. Patrick, welcome to the program.
Thank you very much, Roberto. Delighted to be here.
Patrick, it looks like as years go by, therapies that inhibit the renin-angiotensin system, or RASi as I'll refer to this from now on, they continue to be important tools in the management of patients with CKD. Still in the real world, clinicians struggle to align with recommendation. What is your approach to RASi optimization?
RASi uptitration is indeed desirable throughout the cardiorenal continuum, as universally emphasized by international guidelines. This is true in chronic kidney disease patients with or without hypertension, as emphasized again by the latest 2021 KDIGO guidelines on blood pressure management in CKD, for instance, stating that RASi, S inhibitors or ARBs, should be administered using the highest approved dose that is tolerated to achieve the benefits described, because the proven benefits were achieved in trials using these doses. This is also true in patients with heart failure and reduced ejection fraction, as confirmed by the latest European cardiology guidelines published in August 2021. Importantly, CKD, mostly defined as eGFR below 60 ml per minute per 1.73 square meters, is a highly prevalent condition in patients with acute and chronic heart failure, approximately 1/3, according to a meta-analysis published some years ago by Kevin Daman in the European Heart Journal in 2013 of 57 studies comprising more than 1 million patients. In both settings, especially in elderly patients and in patients with diabetes, hyperkalemia was found a true hurdle toward RASi optimization. In the heart failure setting, we and others reported that hyperkalemia is one of the main triggers of RASi non-use, underdosing, and discontinuation, thereby leading to deprive our patients for these cardiorenal-protective agents and partly mediating the observed association between hyperkalemia and poor outcomes in cardiorenal patients.
So looking at the conversations in nephrology and cardiology, it seems like the community has finally decided to approach the problem of hyperkalemia in a more proactive approach, don't you think so?
Yes, indeed. The latest 2021 KDIGO guidelines on blood pressure management in CKD stated that hyperkalemia associated with use of RASi can often be managed by measures to reduce the serum potassium levels rather than decreasing the dose or stopping RASi, and that potassium restriction, discontinuation of potassium supplements, certain salt substitutes on hyperkalemic drugs, adding potassium wasting diuretics, and all potassium binders. In CKD patients receiving RASi who develop hyperkalemia, the latter can be controlled with newer oral potassium binders in many patients, with the effect that RASi can be continued as a recommended dose. Furthermore, the latest 2021 ESC heart failure guidelines stated that administration of the K-lowering agents patiomer or sodium zirconium cyclosilicate may allow renin-angiotensin-aldosterone system inhibitor initiation or uptitration in a larger proportion of patients.
That's really interesting, Patrick. So you were an experienced clinician, and you probably treat patients with these therapies a lot on a daily basis. Can you provide our audience with your approach to monitoring measures in patients starting in long-term RASi therapies?
Well, it is universally acknowledged that creatinine and potassium must be adequately monitored in CKD or heart failure patients. Why? The proper monitoring was unfortunately reported to be poor after mineralocorticoid receptor antagonist initiation in heart failure patients, both in the US and in Europe. The latest 2021 KDIGO guidelines on blood pressure management in CKD stated that changes in blood pressure, serum creatinine, and serum potassium should be checked within 2 to 4 weeks of initiation or increase in the dose of RASi, depending on the current GFR and serum potassium. Furthermore, in patients at risk for hyperkalemia, measuring serum potassium before and at 1 to 2 weeks after initiation of RASi is recommended. Patients should also be monitored for symptomatic hypotension, hyperkalemia, and serum creatinine within 2 to 4 weeks after initiating or changing the dose of the drug, with the time interval depending on baseline blood pressure, serum creatinine, and serum potassium. Finally, a shorter time interval is indicated if the baseline serum creatinine is high or serum potassium is already high normal, or if there is a history of hyperkalemia or an acute rise in serum creatinine with blood pressure lowering or RASi. As far as the ESC heart failure guidelines are concerned, the latest ESC heart failure guidelines repeatedly stated that in heart failure and reduced ejection fraction, firstly, after ACE inhibitors ARB initiation, recheck blood chemistry, in other words, urea, BUN, creatinine, potassium, 1 to 2 weeks after initiation, and 1 to 2 weeks after final dose titration. Monitor blood chemistry 4 monthly thereafter. A thorough potassium monitoring is warranted in patients treated with an mineralocorticoid receptor antagonist. Check blood chemistry at 1 and 4 weeks after starting increasing dose, and at 8 and 12 weeks, 6, 9, and 12 months, 4 monthly thereafter. Second, a close potassium monitoring is warranted under potassium-lowering agents.
For those just joining us, this is KDIGO Conversations in Nephrology. I'm Dr. Roberto Pecoits-Filho, and I'm speaking with Dr. Patrick Rossignol on approaches to RASi optimization. Patrick, the guidelines are providing a clear message in terms of the importance of keeping patients on these life-saving therapies. However, it's not really an easy task to optimize patients, and this requires a diversity of strategies, different phases of the treatment, acute or chronic, in the hospital or ambulatory. Can you provide some tips on how to optimize the therapies?
Well, Roberto, it should be emphasized that as yet, no monitoring regimen has been prospectively evaluated in patients initiating a potassium-lowering agent for the treatment of hyperkalemia. In an editorial, Bertrand Pitt and I published a couple of years ago in Pharmacological Research 2017, we, however, suggested the following regimen based upon the experience in initiating these agents in the pivotal clinical trials, on our own experience on RASi on diuretic management as a basis for discussion on further prospective evaluation. First, serum potassium should be measured before initiation of a potassium-lowering agent and should be above 5 millimole per liter on a non-hemolyzed blood sample. In patients without life-threatening hyperkalemia, it will be prudent to repeat the measurement and to confirm that the serum potassium is truly above 5 millimole per liter before initiating a potassium-lowering agent. One should also measure serum magnesium, bicarbonate, and assess renal function with the eGFR. Second, after initiating a potassium-lowering agent, serum potassium should be measured within 48 to 72 hours and repeated at 1 week. If at 1 week the serum potassium remains above 5 millimole per liter, consideration should be given to increasing the dose of the potassium-lowering agent and to recheck serum potassium no later than 1 week later. Once the serum potassium is below 5 millimole per liter, it would appear reasonable to, based upon the experience in the pivotal trials of Patiomer and SZC, to measure serum potassium at 1 month and then every 3 to 6 months at regular follow-up visits. Importantly, any time that a change in electrolyte status is suspected, such as during an episode of diarrhea or vomiting, or after each RASi or diuretic dose change, serum potassium and creatinine should be remeasured and the monitoring sequence repeated.
I'm sure that there are different regional realities, but really the fragmentation of care and the problems with the communication between specialties that take care of the patients is really difficult, don't you think? Why do you think this lack of communication exists, especially between cardiology, nephrology, emergency medicine?
Well, Roberto, in my view, the workload is certainly a major hurdle, actually, along with some inconsistencies between nephrology and cardiology guidelines. For instance, regarding thresholds to discontinue, don't titrate RASi in the presence of a worsening renal function or hyperkalemia.
Yeah, I fully agree with that, Patrick. Well, any final advice to clinicians?
Sure. Please don't hesitate to titrate RASi as much as you can whilst monitoring creatinine and potassium closely. And be ready to introduce a new potassium binder to enable RASi, as repeatedly demonstrated with Paraná. For instance, in the Arbor trial, I was involved in the steering committee. In patients with advanced chronic kidney disease and resistant hypertension, Paraná, compared to placebo, enables the more persistent use of the steroidal MRA spironolactone, the primary endpoint of this phase 2 trial.
Well, with that takeaway in mind, I want to thank my guest, Dr. Patrick Rossignol, for joining me and discuss the different approaches to RASi optimization. Patrick, it was great having you in the program.
My pleasure, Roberto.
I am Dr. Roberto Pecoits-Filho. To access this and other episodes in the series, please visit kdigo.org/podcasts. Thanks for listening.
This episode was provided by KDIGO and supported by Vifor Pharma.